Hello students, hope you're all doing well. You're done and dusted with your INI-CET November exams, and the initial reactions that are coming in is that the exam was fairly easy, although there were a lot of questions that were more comprehension based and more into the concept of the question. And that has always been the format of an INI-CET exam. Let's look at the INI-CET exam from the orthopedic point of view. So these were all the questions that came in this INI-CET exam, and it again proves that similar topics will keep getting asked in the INI-CET exam. Although the questions will be different, the questions will be more deeper, more comprehension based, the topics are always going to be similar. Like I've already told you in the prepathon and the rapid revision sessions, there are always going to be questions from these topics like osteoporosis, hip biomechanics, mainly Trendelenburg test, ankylosing spondylitis, bone tumors. There's always going to be a question on bone tumors. There is always going to be a question on ATLS protocol and also a question on nerve injuries. And if you look at the recent pattern of the INI-CET exams, there's a topic that the INI-CET examiners have fallen in love with, and that is proximal femur fractures. So nowadays, you see a lot of proximal femur questions being asked in the INI-CET exam. So the exam was easy, but there have been more topics that have been covered in greater detail. So the moral of the story of anyone trying to write an INI-CET exam, the moral of the story is study high yield topics. Do not go around trying to study everything a few months before the INI-CET exam. Only study these high yield topics and study them much more deeper, much more comprehensively. So that would be the moral of this INI-CET exam. So if you're preparing for the next INI-CET exams, remember that there is a set of topics that are frequently asked, and the questions keep changing, keep getting more difficult to study those topics in greater lengths. Now coming to the recall question itself, before we begin with the recall questions, there are a few things that I want you to understand. This recall questions that I have tried to accumulate is with the help of a large group of students who've given me their feedbacks based on their memory as to what a question is. So this is a memory based recall of the question. So this might not be perfect. Although I've collected it from a large group of students trying to make it as perfect as possible, but sometimes there can be a recall bias in these questions. So please remember that these questions might not be perfect, and if they are not, please leave a feedback down in the comment section, or you can always get in touch with me and I can tell you the answer to the actual question. The second thing is the purpose of why we are doing these sessions. These recall sessions are not for you to sit down and try to calculate your marks and then start regretting about everything that you did wrong. No, this is not the objective of the session. The objective of the session is to help you prepare better for your NEET PG and your subsequent INI-CET exam, and that is why we are trying to reflect on the concept behind the question. We are not just going to tell you the answer. I'm going to tell you the concept and what you need to focus in your next NEET PG and INI-CET exam. Now, keeping these things in mind, let's quickly go into the recall questions. 7 questions were asked from orthopedics. Let's first start with the proximal femur question. So the question, most students have told me it was a question without an image. Few students told me there was an image included. So let's assume that there was no image included in this question. So the question was treatment of intracapsular neck-of-femur fracture in a patient of less than 45 years of age. So the keywords here are intracapsular neck-of-femur fracture and the age, that is less than 45 years. So we are dealing with a question from proximal femur fractures. Now in proximal femur fractures, there are two concepts. The one concept is two types of fracture. One is intracapsular, one is extracapsular. So intracapsular fractures are most neck-of-femur fractures. Most neck-of-femur fractures are intracapsular. They are within the capsule. They have synovium around them and they are called as neck-of-femur fractures. Then we have extracapsular fractures. This is mainly intertrochanteric, subtrochanteric fractures, and one type of neck-of-femur fracture, that is basicervical neck-of-femur fracture. So all of these come under extracapsular. The treatment for them are also different. For extracapsular fractures, because they are outside the capsule, you can always treat them with open reduction internal fixation with the help of a proximal femoral nail or a dynamic hip screw. So this is the treatment for extracapsular fractures. But the question here is talking about intracapsular fractures. Now, how do you treat an intracapsular neck of femur fracture? And in my session, I've dealt with this in great detail. I've told you that every proximal femur fracture, you have to ask two questions. One is, what is the age of the fracture? And second is, what is the age of the patient? Now, if the age of the fracture is an acute fracture, that is less than 3 weeks, if it is less than 3 weeks, then we have an algorithm, and the algorithm is that if you have a neck of femur fracture less than 3 weeks, you have to see whether it is displaced or whether it is undisplaced. Now, in undisplaced fractures, the treatment is closed reduction internal fixation with the help of CC screws. We've discussed about this as well. We'll put the CC screws in an inverted triangular fashion. So that is what is done in undisplaced fractures. In displaced fractures, we'll try to find the age of the patient. If the age of the patient is less than 65 years, then you try closed reduction and internal fixation first. If you're not able to do it, then you go for open reduction internal fixation. If it is an elderly patient above 65 years, then we know that in this hip there is some amount of arthritis and also avascular necrosis that is setting in. So you can't do an open reduction internal fixation. Instead, you'll have to replace a part of the hip. Now, if the acetabulum is normal, you can do a hemiarthroplasty. That means only half of the joint, that is a femoral head, is replaced. But if there is arthritis of the acetabulum also, if there is a hip osteoarthritis, you have to do a total hip replacement. So in cases of above 60 years, you can go for hemi or you can go for total hip replacement. Now let's go back to the question. The question talks about a 45-year-old who has an intracapsular fracture. They have not mentioned whether it is displaced or undisplaced. So let's assume that it could be both. And in both these scenarios, the best answer would be closed reduction internal fixation, because always we give an attempt at closed reduction internal fixation and then go for open reduction internal fixation. So the answer to this question, because it is a 45-year-old patient with an intracapsular neck of femur fracture, the answer is closed reduction internal fixation. Hemiarthroplasty we would have done in above 65 years patient who has a less than 3 week neck of femur fracture, who has no hip OA. Okay. If there was hip OA, we would do a total hip replacement. If closed reduction internal fixation fails, then we do an open reduction internal fixation. Is this clear? Have you understood the proximal femur algorithm? Because this will be asked in every exam. The most important concept in proximal femur fractures is the algorithm. How do you treat a patient of a certain age, and when the fracture is acute and when it is chronic? Okay, so that was the first question. Now let's go on to the second question. This question was from arthritis section. So the question was a long clinical question. A 35-year-old patient presents with complaints of back pain, stiffness and recurrent episodes of uveitis. Imaging was done suggestive of sacroiliitis. Which of the following HLA is commonly involved in this scenario? So this is a long clinical question. The options are HLA-DQB1, HLA-DR3, HLA-B27 and HLA-DR4. Now, if you recall my prepathon and rapid revision sessions, I've told you that whenever you have a long clinical question, always train your mind to search for the keywords. So if you had studied enough, if you had known the correct concepts, you would be able to highlight these keywords that are present here. Your eyes would have directly gone into 35 years, back pain, stiffness, recurrent episodes of uveitis and sacroiliitis. Now, if you remember these 5 keywords and if you've seen my classes on arthritis, you would remember that there is a condition called as seronegative spondyloarthropathy, about which I have already talked. I've told you that seronegative spondyloarthropathies are a group of disorders which have a few common factors. What are these common factors? They are that this occurs in before 40-year of patient. They'll have inflammatory arthritis of axial skeleton and sometimes even large peripheral joints. There'll be absence of rheumatoid factor in the serum. There'll be a strong association of HLA-B27 and there will be presence of uveitis. Okay, now in seronegative spondyloarthropathies, I've also dealt with a topic called as ankylosing spondylitis. Ankylosing spondylitis. And in ankylosing spondylitis, the clinical features of the patient are that he'll be a young male, he'll have pain, there'll be stiffness of the back, patients will walk with a stiff back and they will have pain on getting up from bed or a period of inactivity and relieved by activity. So this is an inflammatory type of back pain seen commonly in ankylosing spondylitis. And if you look at the features of ankylosing spondylitis, sacroiliac joint involvement is always first. So patients will present with sacroiliitis. So is this clear? Have you understood this? We've discussed this in detail in a chapter called as seronegative spondyloarthropathies, where I've told you that all of these features are common in seronegative spondyloarthropathies, and in them, in ankylosing spondylitis specifically, you will see more of sacroiliitis, stiffness of the back and back pain. Now let's go back to the question. Knowing these facts, let's go back to the question. So you know that there is a 35-year-old has back pain and stiffness, recurrent episodes of uveitis and sacroiliitis. Just by knowing that this is a 35-year-old patient who has uveitis, you can think of seronegative spondyloarthropathy. So this is deduced from the fact that patient has uveitis and patient is less than 40-year-old. Now also the fact that patient has sacroiliitis and stiffness of the back, both of this should point towards the diagnosis of ankylosing spondylitis. Ankylosing spondylitis. Now what is the question? The stem of the question is, which of the following HLA is commonly involved? We know that in both these conditions, the HLA that is commonly involved in all seronegative spondyloarthropathies is HLA-B27. So this is how, with the known facts, with the keywords, you are able to deduce what the answer is. So through this, you know that the answer is HLA-B27. The answer is HLA-B27. So that was a question on sacroiliitis, on ankylosing spondylitis. Now let's go on to another question. This is from hip biomechanics. Here they've told you that there is a patient who, when walking, which muscle of his supported side helps in raising the unsupported side. So they're talking about hip biomechanics. They're asking you, when walking, which muscle of the supported side helps in raising the unsupported side? Your options are gluteus medius, gluteus minimus, obturator internus and quadriceps muscle. Now we've discussed this concept as well when we talked about Trendelenburg test, about biomechanics of the hip and also about Trendelenburg sign. So this was the animation that I had shown you in the class as well. So look at this animation here. You have the pelvis, you also have your hip joint and the abductor mechanism. Now imagine that the patient stands on this limb. So this is the supported side, this is the unsupported side. Now imagine that the patient is standing on the supported side. Normally, because there is all the weight going into the supported side, the pelvis will drop down. Can you see how the pelvis is dropped down? Now to prevent this pelvis from dropping down, we have a muscle here. We have a muscle here which will pull that unsupported side back and it will keep the pelvis flat. Can you see what is happening here? That muscle is keeping the pelvis flat. And which is that muscle? We need to know which is that muscle that is keeping the pelvis flat, and that muscle is gluteus medius. We've discussed this in our sessions as well. We talked about this abductor mechanism where a pelvis is kept flat with the help of this muscle called as gluteus medius, which is one of the most important abductors, keeping your pelvis level, not allowing you to bend down, not allowing your sound side to sink. We've also talked about this concept of Trendelenburg test, where if the patient's abductor, if the gluteus medius is weak, what will happen is, if the patient stands on an unsound side where the abductors are weak, the pelvis will sink down to the sound side. So sound side sinks. This is how you will remember it. Sound side sinks. That is, if same side abductor mechanism is defective, that is the unsound side, the opposite side, which is the sound side, pelvis will sink down due to gravity, and that is a positive Trendelenburg test or a Trendelenburg sign. Okay, so this was the fact that we discussed about, and with the same concept, we'll be able to answer this question. Here they're asking you, what keeps the supported side straight? And the answer to that is gluteus medius. It is gluteus medius. So that was about hip biomechanics. Then a question was asked on osteoporosis. This, I have to say, was a bouncer. Not a lot of explanation is there based on this answer. It is a one-liner which is kind of uncharacteristic of an INI-CET exam, because they usually don't go for one-liner questions based on a single fact or a single tool. So they're asking you, what is the full form of FRAX? So FRAX is a tool used in osteoporosis. It is a tool used in osteoporosis where, with the help of certain criterias, you're able to predict percentage of fragility fractures in a person for the next 10 years. So for the next 10 years, you can tell him the probability of him getting a fragility fracture, and that tool that we use is called as a FRAX tool. Okay, it's available in the internet, it's available as a questionnaire, and this is the tool called as a FRAX tool. And the full form of FRAX, because it predicts the fracture risk, it is fracture risk assessment, and instead of the X, it is actually T tool. Okay, so the answer is fracture risk assessment tool. Now, because this has been asked in the INI-CET exam, let's dig a little deeper and try to understand the FRAX tool in detail. So this is a questionnaire, that is a FRAX tool. Here you will have to fill all of these criteria that are there, and that will give you an answer as to what is the chances of fragility fractures in this person for the next 10 years. So what is a FRAX tool? It is a tool that is developed to predict risk of fractures in a person who has osteoporosis for the next 10 years. And you have 12 criteria that are commonly used. I'd like you to remember these 12 criteria. One of the criteria is age, one is weight, there is height, sex, smoking, history of fractures previously, parental history of fractures, presence of rheumatoid arthritis, whether they are on glucocorticoid medications, whether they have any factors of secondary osteoporosis, alcohol consumption, and bone mass density. So all of these criteria are taken into consideration whenever you are giving a FRAX tool, and this score will help you predict whether the patient will get a hip, arm or spine fracture. Arm meaning distal radius fractures, which are the 3 common osteoporotic fractures that you get. So that is about the FRAX tool. Not a very expected question, but somehow it's come up. I hope most of you got this right. Now let's go on to the 5th question. Here they told you that there was an elderly patient with a trivial fall history. Imaging is shown below. What is the diagnosis? Now many students have told me that there were 3 x-rays that were given, although most of the students never came up with a common consensus as to what those images were. What I was able to gather was that 3 x-rays were given. One x-ray was a pelvis with both hip x-ray, where they told me that there was a lot of iliac bone and acetabulum destruction. Hip joint was deformed. Some told me it was also dislocated. There was also a humerus x-ray where you could see some parts of radius and ulna as well, where there was a pathological fracture of the humerus, mainly at the diaphyseal region. There was also a tibia fibula x-ray, an x-ray of the leg, where there were lesions in the bone noted. There was no fracture, but there were lesions in the bone noted. The options given were brown tumor, disseminated TB, metastasis, and eosinophilic granuloma. Now to answer a question like this, although we don't know the images correctly, how do we approach a question like this? See, my approach would be first to understand each of these fractures, each of these diseases in detail. So we've covered about all 4 of these diseases. First, let's talk about eosinophilic granuloma. So eosinophilic granuloma is commonly seen in younger children, and it's usually a solitary lesion. So it cannot be eosinophilic granuloma in all of these 3 areas. Then coming to disseminated TB. Now in disseminated TB, because they've given a pelvis with both hips, there is a chance that the x-ray might have been a wandering or a traveling acetabulum. What happens is, in TB hip, because of gross destruction in the last stages, sometimes the acetabulum is destroyed, even the femur is destroyed, the femoral head is destroyed, and you might have this kind of mortar and pestle appearance, or you might have it wandering acetabulum. Whenever there is some amount of destruction of acetabulum and there is subluxation of the femoral head, you might have a wandering or traveling acetabulum, or you might have a mortar and pestle appearance of the femur and the hip joint. Now that can explain the pelvis with both hips, but it cannot explain the humerus x-ray and the tibia and femur x-ray. So it's logically cannot be a disseminated TB based on the images that were given. Now coming to the other 2 options, that was metastasis and Brown's tumor. Now metastasis is possible in multiple bones resulting in pathological fractures. Even Brown's tumor is possible. You might have these cysts coming in that can give you fractures. But in Brown's tumor, you would expect there to be a few other one-liners, few other statements that suggest that there is some amount of hyperparathyroidism resulting in these kind of fractures, these kind of lesions. Because what happens in Brown's tumor is, because of hyperparathyroidism, there is increased osteoclastic activity. Because of increased osteoclastic activity, there is a lytic lesion in the bone. This gap in the bone then gets filled by blood cells and fibrous cells, and these blood cells will then break down, the hemosiderin will break down, resulting in formation of a cystic brown shaped mass, which is called as a Brown's tumor, and this is seen in multiple bones. So there can be Brown's tumor and it can be METs as well. Now what would be the images that you would expect in a case of Brown's tumor? So this is the first possibility, that they might have given you these three x-rays. One x-ray here where you can see that there is a lesion, a Brown's lesion that has resulted in a fracture. The second lesion may be somewhat like this, where you have destruction of these iliac parts of the bone. So some students told me that there was gross destruction of the iliac bone. So it could be an image like this, which is suggesting that there is a Brown's tumor of the pelvis. And in the leg x-ray, there might have been multiple nodules of Brown's tumors that were present. So this could be one possibility of Brown's tumor, although there is nothing in the question in itself that is talking about a hyperparathyroid state. The second possibility is these three images, and this is something that I'd like to put my money on. I think the options that were given and the images that were given are more suggestive of metastasis, because students told me that there was gross destruction of the pelvis with some amount of dislocation of the hip joint. So you can see here there is gross destruction of the pelvis and there is dislocation of the hip joint. There is a big metastatic lytic lesion that is present. You can see there is a lytic lesion here. Also in this image you can see in the humerus there is a lytic lesion which has resulted in a fracture. And in the third image again you can see there is some amount of metastasis that is present. So it is possible, because there are not a lot of things in the clinical question itself suggesting any other type of TB or any other type of Brown's tumor, because there was a trivial trauma resulting in a fracture, and because it is an elderly patient, it is more suggestive of a metastasis. But then again, because I don't have the right images, I cannot tell you, but more suggestive of either Brown's tumor or metastasis. Strongly believe in metastatic being the answer. So that was about the fifth question. Now coming to the sixth question. Here again, this was on ATLS protocol. There has been repeatedly questions asked from the ATLS protocol. So here they are telling you which of this is not a primary investigation for primary survey in a patient with road traffic accident or a patient falling from the second floor. Few students told me it was fall from second floor. Some told me it was road traffic accident. But anyways, the question does not change in itself. They're asking you which investigations are included in the primary survey, which investigations are included in the secondary survey. Now in the primary survey, even if you don't know the image, you don't know the investigations, just think of it logically. When you have a patient coming to you with a lot of injuries, polytrauma, maybe some life-threatening injuries are also present, what are the investigations that you will get? You will get an EFAST because you want to look for solid organ injuries. You want to know for any bleeding that is happening in the abdomen. You will also get a chest x-ray, because a chest x-ray is going to tell you a lot about whether the patient has pneumo or a hemoperitoneum or flail chest or any other injuries in the any other pulmonary contusions that occur. So chest x-ray is a must. Pelvis x-ray is also important, because we know in pelvis fractures there is going to be hypovolemic shock and patient can die soon also. So you have to get a pelvis x-ray to look for pelvis fractures. CECT abdomen. Now is CECT abdomen, or some people have also told me that it could be NCCT. NCCT abdomen. Could be both or any of these options. Now both of these are not part of the primary survey. This comes under secondary survey. This comes under secondary survey, and we've discussed this in our ATLS session. We've talked about what is the component of ATLS. ATLS has primary survey and secondary survey. In primary survey, you will only do life-saving investigations, important investigations first. You will screen for any emergencies, and after that, once the patient is stable, then you will investigate him even further, and that is when you will do an NCCT or you will do a CCT based on what the condition you are suspecting. So in this question, the answer has to be A. The answer is CCT abdomen or NCCT. Okay. Now let's go on to the last question, and this question is from nerve injuries. Always in an INICET exam, there are going to be questions from nerve injuries. So here the question is, in posterior interosseous nerve injury, dash is affected. Your options are wrist extension, elbow extension, finger extension and supination of the forearm. Now, if you've been following my sessions, if you've seen my nerve injury session as well, you would know that the way I discuss nerve injuries is not by making you remember the whole complex anatomy of every nerve. The very simple way of remembering every nerve injury is to have a memory based remembrance or a pictorial representation of each nerve, which muscle it affects and where the nerve transfers through. So this is the pictorial representation of a radial nerve. I also have images of ulnar and median nerve, which I have talked about in my sessions. So if you only remember these three pictorial representations, you will be able to deduce a lot of things based on the nerve injuries. Now look at this image here. Here you can see that the radial nerve, as it comes in the proximal part of the arm, it supplies the long head and medial head of triceps. As it comes near the spiral groove, it supplies lateral head of triceps and anconeus, passes through the spiral groove, comes into the lateral intermuscular septum. Here it supplies brachioradialis and extensor carpi radialis longus. Then it goes into the elbow. It divides in front of the lateral epicondyle, and here it divides into two branches. One is a sensory branch, which is called a superficial sensory branch, travels under the brachioradialis, and another is posterior interosseous nerve, which is a purely motor branch which pierces the supinator in the proximal forearm, going into the extensor side, supplies the supinator and all the extensors. In the hand, there is no motor supply by the radial nerve, but sensory supply of the hand is present. Now, based on this, you can have different types of radial nerve injuries. If the injury occurs here, it is a very high radial nerve palsy. If it occurs here at the spiral groove, it is a high radial nerve palsy. If it occurs here at the elbow joint, it is called as a low radial nerve palsy. And that if the injury occurs here at the pin muscle in itself, we call it as a pin palsy. Now look at what happens in each injuries. Let's look at pin palsy first. In pin palsy, it's only the supinators and the extensors that are damaged. You still have brachioradialis, you still have ACRL. So what features would you see here? You will see that in pin palsy, because supinators and extensors are gone, you will have a thumb and finger drop. But because ECRL, extensor carpi radialis longus, and ECRB are still intact, wrist extension is present. And also because proximal part is intact, elbow extension is also present. So elbow extension is present, wrist extension is present. Now supination. Now supination of forearm is by two things. One is biceps brachii, another is supinator. So even if supinator is gone, because biceps brachii is present, supination will be present. So going back to the question, in PIN injury, in pin palsies, what happens in pin palsies? In pin palsies, you would have lost your finger extension. Wrist extension will be present, elbow extension will be present, supination of forearm will be present. It's only the finger extension that is lost, because of which you will have a finger drop or a thumb drop. These are the two features that you will see in a pin palsy, and this is how you will differentiate between low radial nerve palsy, high radial nerve palsy and very high radial nerve palsy. In low radial nerve palsy, again sensory involvement will be there because even this branch is gone. In high radial nerve palsy, your wrist is also lost. In very high radial nerve palsy, even your elbow extension is lost. So this is how, based on just this image, you will be able to answer any question that is asked on radial nerve injuries. So this was a session, this is a screenshot of the session that I had taken, in which I have talked about finger drop and thumb drop being present in pin palsy. You won't be able to extend the fingers at the MCP. No sensory disturbances there. Examples are radial head fracture, radial head dislocation and Monteggia fracture. So this was the answer, finger extension. So these are all the questions that were asked in the recent INI-CET exam. If I have to give a reflection of how the exam was, I will tell you that it was an easy exam if you understood the high yield topics, if you studied these high yield topics in detail. Now following this exam, I know that you will be in a happy or in a sad mood, and I don't get to dictate as to what mood you have to be in, but even though you're sad or you're happy, the one emotion that I still want you to have is be motivated, because you may have to fight through some bad days if you want to earn the best days of your life. And these best days of your life can be because of your INI-CET exam now, or it can be after your next NEET PG exam or your next INI-CET exam. So keep giving it your best, and somewhere down the line, you're going to have the best days of your life. Saying this, I'd like to conclude this recall. Happy learning.